Welcome back to Align Yourself podcast. I'm your host, Ebony. And before we dive into today's episode, please forgive me. I'm currently recovering from a lost voice and blocked sinuses. So if I sound a little bit different, that is why. Life has been incredibly full over on our end lately. And this is actually our first episode back after an unexpected break. In that time, my husband and I got married and we celebrated with our family and our friends on our property, Coastal Hideaway, which we have since opened to the public for booking. So it has been a really beautiful and busy season for us, but I'm very excited to be back behind the mic. Today, I'm joined by Stu from Birthing Instincts, an obstetrician and gynaecologist who has become well known for speaking openly about birth, women's autonomy, and the importance of returning to instinct-led pregnancy and birth. In this episode, we're diving into the current state of maternity care, why birth trauma rates are rising, and the role of instinct in pregnancy and labour, hospital versus home birth, and the importance of protecting the mother-baby bond. Stu, welcome to Align Yourself podcast. Thank you so much for joining me today.
Ebony, thank you, and congratulations to you and your partner. That sounds very exciting. I'm very happy for you, and thank you for having me. It's always an honor, actually, to be asked to speak. That means people actually want to listen, and I love speaking to an audience that might not normally hear what I have to say. Although I do speak a lot to people in your country, I have a good feeling about Australia. I mean, I know there's a lot of problems with Australia, and there's a lot of problems everywhere, but with birthing in Australia. But I did get to spend last year. I spent almost 6 weeks there, getting around teaching, and so I have a real strong innate feeling about your country. So thank you for having me.
Thank you. Well, I'm glad, and thank you for your patience, us trying to navigate time differences. And anytime I'm speaking to anyone in anywhere in the world, navigating the time difference is always tricky because we can plug it into our calendar and it comes up still incorrectly. So we've had a lot to navigate. So
Well, my country is still one of the silly countries that does what's called daylight savings time. And last Sunday night, we moved our clocks forward an hour. So 350 million people, except for a couple smart states, 300 and some million people have to have their sleep disrupted and shortened just so that we have an extra hour of daylight in the evening. And then in the fall, we'll fall backwards and we'll set the clocks back again. And there's a nice movement in my country to get rid of that. We should just realize there's 24 hours in a day and stop monkeying with everybody's sleep cycle, which is kind of what happens because we were supposed to be 18 hours apart, and then it was, or 17 or 19 hours apart, and then we got messed up simply because of this silly thing that happens.
well, Stu, for the person that's sitting here with us today listening to this conversation, if they were to take one thing from you, what would it be?
God, I have so many things, but the basic message is that pregnancy is not something to be feared. Pregnancy is not a disease. Pregnancy is something that your body does really, really well. It's designed to do it, very much like breathing or digestion. It just does it without you having to think about it. And on rare occasions, it goes awry. And when it goes awry, medical attention is important. But the idea that we have taken something that 100 years ago, 95% or more of people did at home, and within a matter of 30 years, through propaganda, through marketing campaigns, through very dastardly things, they took this beautiful thing and they turned it from this life event for a family into a medical event, moving women out of the home into the hospital without really actually knowing ahead of time whether this was going to improve outcomes or not. And, in hindsight, you look at it and it was very monetarily motivated. A lot of people made a lot of money by moving pregnancy inside the medical community and making it pharmaceutical based. So I just want women to understand that fear permeates the obstetrical profession. Doctors are taught in a fear-based way, and then they learn to fear birth and therefore project it onward to the women that they care for and their families. And that is really sad because how we come into this world, nothing could be more important. Our health, our immune systems, our attachments, all those things depend on how we come in the world. And we've really taken that and turned it into this medicalized cascade of interventions. People may have heard that term, and really sucked the joy out of it. Most women, when they're pregnant, are it's the best thing they could have ever done in their life, and yet they're nervous about it. And so that when their baby is developing, they're worried because the medical system is implanting these fears inside of you. And once you implant fear inside of somebody, you can manipulate them very easily. It's a long answer to a simple question that pregnancy is designed by Mother Nature to work well most of the time. It works well in all of our mammalian relatives throughout the world. We don't do to them what we do to the human female, and yet they seem to be doing mostly, for the most part, just fine. Every now and then a vet needs to come in when your pet is having a baby, but most of the time they don't. So that is my message in life at this point in my life is to, I've taken a special interest in breech and twin deliveries, but I really want to emphasize the things that I learned, not in residency, not in medical school, but I learned from actively practicing and with a good fortune of being exposed to midwifery early in my career. And they're the ones that influenced me more than anything else. Their model of care made much more sense to me than the things that I had learned in residency. And it took a long time to sort of beat the obstetrician out of me. Still, you can't beat it all out of me. But now I look at the data from your organizations, you it's RANSCOG, me it's ACOG, and I look at the data with a different eye. I'm very skeptical because the outcomes that we have seen over the last 50, 60, 70 years have seen skyrocketing rates of intervention without concurrent improvement in outcomes. So why are we doing these things? And what have we done to our species and our children and our future generations? And I'd like to try to make a change for that. And if I can make women feel more confident in their birth and be able to challenge the current medical doctrine or dogma, then I feel like that change may come, and we'll see better and happier outcomes.
So, Stu, can you take us back? Can you take us back to your career and what led you to having that realization that something was wrong and that something that needed to change?
Yeah, Ebony, thanks. Thanks. This is my origin story. I'll try to be brief. I could spend a whole hour talking about it. I went to medical school at a typical university medical school in Minnesota, in the United States. And in your first 2 years of medical school, it's changed a little bit now, but not drastically. The first 2 years of medical school, we spent entirely in the classroom and the lab. And the second 2 years, you spend doing rotations, clinical rotations on different services. Some of them are mandatory, like internal medicine and OBGYN and surgery and pediatrics. And others are elective, things like ear, nose, and throat and neurology and dermatology. And then in your third year in medical school, as you're finishing it up, wrapping it, going into your fourth year, you have to make a decision that I always say I was totally unprepared for. I think, and that decision is, what am I going to do with the rest of my life? Because you have to decide which specialty you want to apply to residency training for. And I think it's very similar in your country. It might be slightly different, but it's very similar. So you apply to a residency program, and then I picked OBGYN, and I picked OBGYN because I had come off of a service where there was death and disease and sadness involved, and I came on to a service where there was joy and wonder. And even though it was very medicalized and every woman was on her back and every woman got an episiotomy, I was up at 3 a.m. catching a baby. And this was just something I said, this is a great thing. And it just resonated with me. So that's what I chose. And I matched my residency. This is one of those sliding door moments in your life. You open up an envelope in the third week of March, and it tells you where you're going to be doing your residency after you've applied to different places. And I matched in Southern California at a hospital called Cedars-Sinai Medical Center. And I had the good fortune of that hospital being affiliated with LA County, Los Angeles County USC Women's Hospital. USC stands for University of Southern California. It was the busiest hospital in the country in the early 1980s. They were doing about 22,000 births a year there, which if you break that down is 65 babies a day. And I spent 4 months there every other day. So you can do the math and you can see that I saw everything. And everything was just considered our job. Whether a woman came in with a normal delivery, a preterm delivery, a woman came in with a medical problem, heart disease, whether she came in with twins or breeches. We just took on whatever came, and we didn't really look at them as something to be feared. And we learned that breech and twin vaginal deliveries were normal, and we learned the skills to do them. But I finished my residency in 1986, and I came out into private practice. And in 1986, medicine in my country, I think even in your country, was still very different. Doctors came out and built their own practice from scratch. They were self-employed, and they had to get their own patients, and had to get privileges at a hospital, but they were independent. Nowadays, doctors tend to be salaried employees of some large organization. So their responsibility is not only to the patient they're taking care of, it's also to their employer, their boss. And they also work a shift and get paid a salary. So there's less, I would say, devotion to the individual patient because you don't know them. You're working a shift on call. You take care of every woman that walks in over those 12 hours, and then you go home. And the women that you may have been taking care of prenatally are delivering with some other stranger. It's not a good system for either, for satisfaction. Anyway, I didn't have that, but I had to build a practice. And another sliding door moment for me was when I came out and I was approached by a couple local midwives in Southern California and asked if I would be willing to take their home birth transports. And I said, sure. And why did they approach me? Because I was the young doctor in the community. And I don't know, they assumed that I would, they were looking for somebody to give them backup. And they knew that I was hungry, looking for work. And I said, sure. And that's a very important point is I didn't say sure because I thought that home birth was a great thing or midwifery was a great thing. I didn't know anything about it. I'm pretty sure that I don't remember, but I'm pretty sure I probably thought home birth was foolish, just like most OBs still think because they don't know anything about it. I did it so that I could make money because every time a woman got transferred to me, I could bill her. We had private insurance and we didn't have socialized medicine in the United States, and I could bill her and make money and build my practice. And that's what I did. Little did I know how much that would change me over the years because they began to ask me questions about why I'm doing certain things. And I began to ask them questions about why they don't do certain things and why they do it this way and I do it that way. And when I was hearing their answers, it made a lot of sense to me. And when they were asking me simple things like, why are you clamping the cord right away? Why is she delivering on her back? Why do you cut episiotomies on everybody? Why do you take this baby and take it over to the warmer when it's done? Why don't you just give it to the mom? And I had to think for a second, and this is a composite memory, but it's like, I don't know. Why am I doing those things? They don't make any sense. And so I began to learn from the midwives how to do things differently. I still had all my base knowledge and my education from my medical training, but I knew nothing about normal birth. And I would say most doctors nowadays know nothing about normal birth. A typical OB will protect his turf and say that that's crazy, Dr. Fischbein. I know everything about normal birth. And I would say, no, you don't. Do you let a woman deliver unmonitored? Do you let her squat? Do you let her eat? Do you tell her that she's got to be induced because she's over 35? Do you tell her these things? And the answer would be yes, of course I do, because that's the standard of care. I said, that's your standard of care, but that is not the standard of care of the midwifery model of care. And if you look at pretty much all the world literature on outcomes between midwife cared for patients and OB cared for patients of a similar, what's classified as low risk, I hate that term, but we'll use that term, low risk women in pretty much every aspect of care and satisfaction and outcomes, the midwifery model of care is an improvement over the obstetric model of care. So it just took, that's sort of how I did. And over time, I realized that midwives had a lot to offer. So then I started a collaborative midwifery practice in my 10th year in private practice. I had to move to another hospital because the Cedars where I was working all those years, they did not allow midwives to have privileges there, but there were some hospitals up north that did. So I moved my practice mostly up north. For a while, I drove back and forth 60 miles between two counties. And that was a little bit crazy on me and my family life. But I moved up north, and for 15 years, we had a really good thing going. The midwives did what they do best. They took care of all the normal stuff, the normal well-woman exams, the annual pap smears when we still thought annual pap smears were necessary. It's another conversation. Um, and the normal births and the normal prenatal care. And if a woman had an ectopic pregnancy, then I would take care of it. If a woman needed surgery, I would take care of it. If a woman had a breech baby, then I would take care of it. And we had really good numbers. We had a 7% C-section rate in our practice, whereas at that time, the average practice in Southern California had a 26 to 28% C-section rate, and ours was 7. Now the C-section rate in your country is probably over 40%, and in our country it's bordering on 35%. And so we've done all this increase in these interventions without any real benefit and outcomes. We can talk about that down the road. So after 15 years, however, so now I'm in practice almost 25 years. The medical community never accepted us. They were always picking on us. And this is typical of what happens when you are bringing something new into a community. It makes the establishment very nervous. And it makes them nervous because they're uncomfortable and because maybe they're realizing that maybe we're not doing it right, but they don't want to admit that. So they start to pick on you, and they start to then eventually they banned vaginal birth after cesarean. Then they banned the midwives from the local hospital where our office was, where we'd have to drive 20 miles to another hospital just to do our deliveries, even though our office was across the street from the hospital. And then they were going to ban breech delivery. And it got to be the point where I wasn't always cooperative with them because I looked at them I looked maybe a little arrogant, but I looked down upon them because if a woman broke her bag of water, she had to come in immediately and get induced. They had, like I said, they had C-section rates of 25, 26, 27%. They did things that I thought were wrong, that I would have thought were right 20, 25 years earlier when I came out of training, but that I had learned were wrong. And because I was the outlier, I made the anesthesiologists, the pediatricians, the labor and delivery nurses uncomfortable because their OB colleagues were telling them that Fischbein guy, he's crazy. He's doing crazy things like breech delivery. And we all know breech delivery, well, the babies will certainly get their head stuck and you don't want to be involved in that. And so the nurses were nervous, the anesthesiologists were nervous. Plus our patients didn't want epidurals. They wanted to go home right away. The hospital, apparently we didn't generate as much revenue as the other services did. I didn't know this at the time, but I think that plays with the administration of the hospital, because the administration of the hospital, contrary to what your listeners might think, is not interested in your well-being. Their ultimate goal is to generate revenue to keep the hospital financially viable. And they make 2 to 2.5 times as much money when you have all these interventions and a C-section than they do when you come in, have a vaginal delivery, and go home in 12 hours or 6 hours or a day, whatever. And that sounds very callous, but that's their responsibility. The people that run the hospital are responsible. They want you to have a good outcome, but it's not their primary concern. Whereas my primary concern was granting the woman her choices and then honoring them and giving them what they want. And so we eventually got to a point where they were going to not renew my privileges, which is their right to do that. Every 2 years, a doctor, at least, I don't know if it's still every 2 years, most hospitals will have a thing where you have to renew your privileges. And it's kind of like belonging to a club. Every year you have to pay your dues. But if they don't want you in the club anymore, they can't just kick you out. But they can just say when you're up for renewal, you know what, we've decided we don't want you. And that's perfectly their right to do that. And so I had a choice of either fighting them legally, which is a monstrous thing to take on for a little person to fight a big corporation. I mean, the hospital I worked at was a national corporation, or to then leave and start doing home births. Fortunately, I had such a good relationship with the midwives of Southern California that they all encouraged me to do that. And what's really interesting, Ebony, is that I had been practicing with midwives for almost 25 years, and I had yet to ever attend a home birth, even though I'd been taking home birth transfers for that entire time. And that just goes to show you that the two professions are really siloed. There really is no mixing between the two. And that's a mistake for both doctors and midwives and the women we care for, because that collaboration isn't smooth between the two.
So even in that time, may I just ask, you are now on the opposite. You're a woman's having attempting a home birth, and for whatever reason, she needs to transfer into hospital. So you're on the other end. Did that not make your view on home birth even worse than what it was? Because you're then I'm putting myself in a position where I had my first daughter as a home birth, and I transferred in after I gave birth, about an hour later, and my transfer led to the obstetrician on the other end looking down on home birth even more because they looked at it as foolish and irresponsible. Did that not shape you having more of a negative viewpoint on home birth from receiving transfers?
No. And, it might have had I not had been working with midwives for many, many years. What I learned about home birth transfers is that almost all of them are non-emergent. They're almost all for labor has stalled, mom's exhausted, baby's not tolerating labor well, maybe membranes have ruptured and it's been 2 days or 3 days and nothing's happening. And the midwife gives the woman the options and the woman says, yeah, I think I'll go in. And they come in and they get an epidural and they get Pitocin and and 90% of them went on to deliver vaginally. Every now and then there would be a disaster that would come in from home birth. And that's the kind of thing that gives home birth a bad name. But the problem is that those same disasters happen in the hospital every day. And they're just considered normal in the hospital. There's this old saying that says, when bad outcomes happen at a home birth, it's because of the home birth, and when bad outcomes happen in the hospital, it's because of birth. They don't say it's because of the way the hospital managed you at birth. They don't ever say that. So no, I took it as midwives being maybe I'm just summarizing it wrong here, but being intelligent, being caring, being nurturing, and saying, you know what, I'm outside my scope of practice now. So this is something where we need to bring in an expert in problem birthing. And stalled labor is not the same as a woman who's having a seizure from preeclampsia, but midwives were just honoring basically their code of ethics to do the right thing by their patient and be responsible for their patient's well-being. And some midwives were more quick to transfer than others. And that wasn't for me to say one way or the other. I was just somebody there to serve them and learn from them and deal with them. So it's a really good question because people think that there's always a serious problem when you're transferring a home birth. But that's not the case most of the time. And then I want to say this about this idea that when something goes awry at home, first of all, two things. One is things rarely go awry suddenly at home. Because when you're not meddling with Mother Nature, when you're not starving a woman, immobilizing a woman, hyperstimulating her, anesthetizing her, interrupting her all the time, you rarely see this rapid deterioration of the fetal status that you sometimes see in the hospital where they do a crash C-section and they say something like, God, what would you have done if you'd been at home? Not fully understanding the fact that these things are very, very rare at home. Because when you don't meddle with Mother Nature, you can kind of see a problem coming from a long way off. And midwives were trained, again, in normal birth. And being trained in normal birth makes you an expert in abnormal things because I use this analogy all the time. I think it makes a lot of sense. When you live in the same house for 20 years and you go out for dinner and you come home at night and the chair in the front hall is moved 3 inches from where it normally is, you immediately know something's not right. You don't know what it is. You don't know if there's been an intruder or the dog hit it or there's an earthquake or your mother-in-law came over and to pick up the mail and knocked the chair. You have no idea, but you know something is wrong. And that's how the skill that I attribute to midwives who, since they're so well versed in normal birthing, when something isn't normal, they recognize it right away and they don't wait till there's a terrible problem. So that's why I think that, no, I didn't ever look at home birth as being something that was a bad choice. Maybe early on, I looked at it simply as a choice that helped make me more revenue. Because really, I still was very medicalized in the very beginning, but I took on all comers because I learned as a young kid from my parents and my neighbors and relatives to respect individual decision making. And One of the basic tenets of medical ethics, Ebony, is that given the same information, it's not reasonable to expect two people to come to the same conclusion. And yet,
Mm.
the medical world expects all people to follow exactly the same path for exactly the same issue. All diabetics are treated this way. All women over 35 are treated this way. All women with breech babies are treated this way. All women with twins are treated this way. No, there are many different paths that you can go. And every woman and every family has their own values, their own experiences that influence their decision making. And we are not there to judge them. We are there to facilitate them, to work for them, to help them get the best outcome possible, even if it's something that we ourselves wouldn't do.
Yeah, going back to what you just said about midwives, and how they are trained in more natural birth than what you say obstetricians were. Do you still believe that's the case, that midwives are still being trained in that same way?
Depends. Now, the term midwife is very broad nowadays because it includes the traditional midwife who has only had a training through apprenticeship and traditions passed down through generations, all the way to like the certified nurse midwife who has a bachelor's degree, then a nursing degree, then a certified nurse midwife degree. It generally works in the hospital, is very medicalized. So you have to, when we talk about midwives, we have to break it down into what kind of midwife we're talking about. Um,
Mm.
I think that the traditional midwifery is something that is being lost because of the monolithic thing that the medical cartel has become, this blob that has really taken over everything, and they want to control everything about women's health. They don't want women to be able to choose alternatives. In my country, in the 19 between 1920 and 1950, the organized medical industry took on alternative alternative care like midwives, naturopaths, homeopaths, and they went on a campaign to vilify them and to push them aside. And they took over. And the same thing's happening in your country to midwives, the traditional midwives that work in the what do you call it, the outback, or where they work, in the small communities where major doctors and major centers don't want to go. They put more and more limitations on them, which then restricts the choices of women and makes women have to choose sometimes to birth alone as opposed to going to the hospital because they don't want to go to the hospital. Because maybe their life experience is that they've had a bad experience at the hospital, or their friend did, or their mother did, and rightfully so. There's a lot of bad experiences that occur at a hospital. So when you use the term midwife, we really should be more specific and say what I'm saying is like the traditional um, midwife who takes classes, who goes to school, but sort of learns from the apprentice model. That's the kind of midwife that I work with mostly. Although I work with certified nurse midwives, what we call licensed midwives, what some people call certified professional midwives. And I took transfers from underground midwives, people in California that were working without a license outside of the law. Right. I
What's your
supported because
viewpoint?
I supported the women that needed the help. That was my calling.
We're having a big push for midwives who are feeling that heaviness and all of their strings getting cut, and taking it upon their responsibility to deregister themselves from the system. And I guess, like using your words here, going underground. What is your viewpoint on that? On,
Well,
I guess, we're supporting
yeah,
free birth.
again, people with power like to have power. And usually it's for power's sake. Because the people that want to take over midwifery, that want to license everybody, they're not looking at outcomes. They're just they think that licensing equals safety. And I can tell you that, that they have nothing in common. All right. Why can I say that? Because some of the dumbest, stupidest, most outrageous things that have ever been done to women have been done by licensed, board certified fellows of Ranscog, and yet they do these stupid things. So just because you have letters behind your name and you're licensed and you're, quote, board certified does not necessarily make you a better practitioner. I mean, I was board certified for 20 years. And then because of circumstances, I gave it up. Well, they made me give it up, but I gave it up. I didn't fight them. And the day that I was no longer board certified, was I suddenly a worse physician? And the answer is no, of course not. I think I got better because I was freed of some of the restrictions that they put upon you in order to maintain your board certification. I could learn other things. I could take my continuing education wherever I wanted to take it, as opposed to where they wanted me to go. So licensing is one of these things that it's a false sense of security, and it's really done to control you, midwives in the state. If they really wanted quality, they would take a deep look at the medical model, and they would say, well, with your model, you're all licensed, you're all board certified, you're all fellows of the college, and yet your postpartum hemorrhage rate has doubled in the last 15 years. Your rate of admissions to NICUs has doubled in the last 30 years. The induction rate has tripled in the last 35 years. Your C-section rate has gone up 600% in the last 50 years. The rate of neonatal death and neonatal mortality has not improved. The rate of maternal mortality has probably gotten worse. So who needs regulation? These people are all regulated. They're all licensed. They're all board certified, and the outcomes are getting worse. So there is no correlation. I want to say this very, very boldly. There is no correlation between so-called standards of care and board certification and licensing and quality of outcome. There isn't. I don't want to take most of my brethren to task in this format, but I would love to have a debate with somebody from RANSCOG or ACOG or whatever, and on a public forum, not through Zoom or not through texting back and forth, or certainly not on Instagram in the commenting section of Instagram. God, what a cesspool that is. But on a public stage, in my country, in your country too, wouldn't we have benefited from during COVID? I don't know who your COVID czars were and all that stuff. I just know in my country, everybody knows who Anthony Fauci was. And early on, when Trump was president and then Biden was president, wouldn't it have made sense for the president of the United States to say to Anthony Fauci, Anthony, there's a lot of questions that are coming up, and a lot of people are wondering what's going on here, and some people are suggesting that ivermectin or hydroxychloroquine or maybe lockdowns aren't a good idea, or maybe remdesivir and hospitalization on a respirator aren't working so well. So I'm going to get 2 hours of public television time, and I'm going to put you on a stage with, say, Jay Bhattacharya, who wrote the Great Barrington Declaration, one of the co-authors, who's now happened to be our director of the National Institute. Now he has Fauci's job, or Francis Collins' job, but it would have been, ironically, would have been Fauci's boss. And I don't know if your people know who these people are, but you have your own people in that country. Wouldn't it have been great to put two people on to have a debate so that the citizens of the country could then make their own decision, as opposed to being fed propaganda and being told that that's whatever someone else is saying is misinformation and having to have them censored and shut up and all that thing. Let people make their own decisions. Oh, no, they're not smart enough. They can't make their own decisions. The idea that when you're in a hospital that you're only 60 feet away from an operating room is a false sense of security. Because when something happens suddenly, like the heart rate drops or the cord prolapses or the placenta abrupts or the uterus ruptures in a VBAC or even whatever, and you need to get a woman to the operating room, you probably have about 8 minutes, maybe 10, before that baby suffers an irreversible brain injury or even worse, death. And I can tell you that 99% of hospitals can't get a woman from a labor room into an operating suite with a crew that knows what they're doing and an anesthesiologist and 2 surgeons in 8 to 10 minutes and get that baby out. So you're still going to end up with a bad outcome. And the bad outcome happened most likely because of the way you were being managed in labor. So there's a false sense of security. When you have a bad outcome at home, yes, you end up with a bad outcome. But being in a hospital it makes you more likely to have that bad outcome and less likely to be saved by the hospital. I just want people to understand that you don't have 20 or 30 minutes if a baby is truly suffering a hypoxic event. You just have minutes, and they can't get a baby out faster in a hospital in minutes. That's going to make a difference. And these are the kind of things I would love to debate with somebody who believes otherwise. I really would, because I spent 25 years working in the hospital and 12 and a half, well, 28 years if you include my residency, and 28 and 12 more years in the home birth world. I'm one of those rare people that have lived in both worlds, and I've seen both. And right now, I have no dog in the fight anymore. I'm not practicing anymore. I don't make a living off of talking women into having a home birth. I just am trying to preach honesty and the fact that no one knows what the outcome is going to be, but there are many different ways to to get a baby in a bassinet, and it doesn't have to be the hospital's way only, because the hospital's way hasn't served us well. Just look at outcomes. Your doctor may be a lovely person. She may be, you may have a really great relationship with her and stuff like that. It doesn't matter. She's she's just a cog in the wheel there, and she doesn't necessarily have the ability to do things differently. If her boss or her partners don't want anyone to go past 41 weeks, she's going to have to tell you not to go past 41 weeks. If their office bans VBAC, vaginal birth after cesarean, then she's going to have to skew her counseling to get you to have a repeat C-section. She's not free to tell you the things that you need to know or to support you in your own decision making. Sorry about going off on tangents like this, but I get really, obviously my passion is obvious. I wear it on my sleeve, and I have my "I will not comply" T-shirt on today, so I'm just
I
feeling it.
love
I'm feeling it.
I was going to say I actually interviewed a beautiful friend of mine on the podcast a few episodes back. If anyone wants to go back and listen to it, but she shared her heart wrenching story of losing her baby, and she was in hospital and she had a prolapse. And it's actually a little while ago that I interviewed her, and I haven't listened to it in a while, so if I've used that term incorrectly, I apologize. But I'd strongly urge everyone to go back and listen to her story. But she shared exactly what you said, that even when you're in hospital and you have that, the outcome may still be the same. And I actually asked her, I said, Tori, being a mother myself who had a free birth, because I was so off of the obstetrician that I saw, the people that I met when I transferred my first daughter after a home birth, I was so traumatized. I had so much hatred and fear and anger from that. I was like, I'm safer in my own hands. And I said to her, "How does that make you feel?" Because I was assuming she would be like, "You could lose your baby. I'd never put myself in the position of doing that, and that's irresponsible." And she said, "I if I could do that, I would have from the get-go." And so I was like, "Oh, wow, that's really interesting to hear," because, yeah, birth trauma is skyrocketing. In Australia, it's 45.5%,
I
and
know. I just wrote that. I
the
just wrote myself a note to bring that up, and I'm glad you brought that up. I followed that. Your government did a study, and I did one in England, and they got a really similar number of about 45%. And I would really say that it's higher, Ebony, because
yeah.
I don't sometimes think that subtle language of coercion or
Mm,
bullying is considered by many women to be trauma. So it depends on
mm.
how you define trauma, because there's so much bullying that goes on, gaslighting and coercion. And go ahead. Sorry.
And not a lot I've spoken to a lot of women in the community over the years, and I just listen, and you can hear that there's a lot of disassociation or disconnection from what they experience to what they're feeling. And then I wonder if those statistics are extremely incorrect, because a lot of, I guess, women have been told, and then so they believe it within themselves, or at least I'm alive and at least my baby's alive, but they're missing the fact that they may have been abused, or they may have had an episiotomy that they didn't need. And for me, someone who has never had an episiotomy, I'm sitting on the opposite. And sometimes when something happens to you, you don't realize how traumatic it was to you until you're on the opposite end and you're hearing and you're going, wow, that must have been extremely traumatizing. So I'm wondering if there's a lack of women even acknowledging or realizing what happened to them was extremely traumatizing.
Oh, I can't answer that directly. I can only say that even if it's just if 45% of women are traumatized in the hospital birthing in your country, and then every year on their child's birthday, they're going to relive that trauma. Because tell me a woman who doesn't, on her child's birthday, doesn't recall the birth of their baby. That's sort of, that's where your mind goes. It's how I'm not a woman. And I still, when my daughter's birthday, I still picture the first time I saw her. as she came out. My baby was born by cesarean, but yeah, but a lot of people don't think that, all my family has had home births and breech births. It's like, nope, they don't listen to me. Think about this. What's happened to the human female in the time of the experts, obstetrical experts, and now especially called maternal fetal medicine, which, by the way, was founded in 1977 in my country, the Society for Maternal Fetal Medicine. How have we done since 1977? Does any woman listening, do you guys believe that your grandmother's time, the C-section rate was 5%, and in your time now it's 40%? And why? Did women's pelvises suddenly shrink? Did babies suddenly get huge? Did babies' heads get bigger? Did women become less able to push a baby out as nature intended? No, that went high. That went that high because of the things that these so-called experts have done. Because if they were doing things that were beneficial to us, we would see a falling rate of neonatal mortality and morbidity. We would see a rising rate of maternal satisfaction and a lowering of maternal morbidity. We're not seeing that. Despite all of the things they're doing, all the fetal monitoring, all the laboratory testing, all the medicines they've come up with, antibiotics and Pitocin and other drugs to stop preterm labor and to prevent seizures and all the ultrasounds that they're doing and all the color flow Doppler ultrasounds and, all this stuff. And our outcomes are not better. The only thing that's better is the revenue generation. Even in a country that has socialized medicine, institutions get paid for what they do. So the hospital that does more stuff is going to get paid more money by the government than a hospital that does less stuff. So if you're running a hospital and your job is to make the hospital financially viable, what do you tell your charge nurses and your doctors to do? You tell them to do more stuff. And then you tell them that the reason you're doing more stuff is for safety. Because then they can justify doing it. It's a way of coping with what's called cognitive dissonance. How does a doctor look at the statistics and justify the system that he or she is working in? There has to be a cognitive dissonance. There's a breakdown in logic because they think that what they're doing is safer, and yet safety isn't improving. So it's like, well, wait a minute. It can't be both. It can't be safer, and yet we're getting worse outcomes or not better outcomes. There's something wrong with your logic, but nobody's willing to look at it. Let me, if I can digress for a second with this example. The C-section rate in your country is, let's just say 40%. The World Health Organization, which is not an organization that I have much respect for, people could probably have guessed that, but for the last 40 years, they've said that the ideal C-section rate in Western countries is between 10 and 15%. Now, if we're going to follow the World Health Organization's every word about viruses, how come we're not following that one? And how come we're not saying that maybe, that anything above 15% outcomes don't improve, which is what the World Health Organization says. So let's just say, for the sake of easy math, that the World Health Organization says it should be 20%. They don't say that, but let's just say that. And your rate is 40%. Anybody with common sense would say, well, that would mean half of all C-sections being done are not necessary, which would mean hundreds of thousands of unnecessary C-sections. I don't know what the population in your country, thousands and thousands of unnecessary major abdominal surgeries on women in your country. In my country, it would be like 600,000 unnecessary surgeries because we have 350 million people. Let's just assume that half of all C-sections being done, according to the World Health Organization, and it's more than half, but let's just say half, are unnecessary. But here's the question. Here's where the cognitive dissonance sets in. Because how many doctors go home at night and say to their spouse, hey, honey, guess what I did today? I did 2 unnecessary C-sections. No doctor says that. They all believe that every section they're doing is necessary, yet half are unnecessary. Your mind has to explode at the illogic of these people that are supposed to be the leaders of women's health. It makes no sense. And I can't get anybody to explain to me the answer to that question. How can we go from a 5% C-section rate in 1970 in your country to a 40% C-section rate now and not wonder about the people that got us here? And what really amazes me is that reporters, journalists, and politicians, when they need information about obstetrics or maternity care, who do they go to? They go to the same people for a soundbite or for advice that has led us into this place where we're such a mess. Who should they go to? They should go to the traditional midwives and ask them, how come you have a 4% transfer rate and a 3% C-section rate? And you do twins and breeches. You've done them for your entire career. How can you do that? But they don't, because the power is concentrated in people that want it. And most midwives and most independent doctors are not hungry for power. Midwives aren't hungry to make a lot of money. Midwives don't get rich. Right? Who makes the money in medicine? It's the management. It's the administration. It's the lawyers, the risk management lawyers, and they are the ones that make all the money. And the people providing the care, the everyday nurse, the everyday doctor that's working a shift gets a salary, and it's probably a third or fifth or a tenth of the salary of the person that's running the practice or the hospital, who's working 9 to 5, who's never on call. It's all backwards. It's all backwards. And I think that if people actually took the time to look at it, put aside their discomfort with having to look deeply at it, they would see that what I'm saying and what you're saying, Ebony, is right. There's something really busted and broken about what's going on, and our outcomes for our mothers, our babies, and our future generations are not getting better. Our immune systems begin in the womb. We've never had a sicker generation of children. Now, people can blame 5G. They can blame the vaccines. They can blame glyphosate if you have that in your country. I don't know if you do. If they can blame crappy food, they can blame geoengineering. They can blame anything they want to blame. But nonetheless, the outcomes are getting worse. And although correlation and causation don't necessarily apply, the rising autism rate and the rising rate of chronic illness has paralleled the rise of C-section and the rise of anesthesia and the rise of interventions into deliveries. And at least someone should be taking a look at that. And how, we know that our immune system is affected by our microbiome. And, 80% of your immune system takes place in your gut. And we have now got 40% of babies or more in your country that are being born through a sterile field. They're not being exposed to the trials and tribulations of labor and the bacteria of mom and the skin to skin and the stem cells that they get from delayed cord clamping. All those things have been denied. We've had generations of people were born with immediate cord clamping, denying them something that nature put in motion. We don't immediately cord clamp any other mammal. I've watched births of other mammals. Yeah, a lot of times the cord snaps. By the way, the babies don't bleed to death when their cord snaps. In the mammalian world, an elephant falls out of its mother onto the ground and rolls down the hill. If you've seen that video, and the baby's fine. But nature has designed a process for us to be born. And modern medicine has done everything they can to intervene in that process without any long-term consideration of what happens downstream. They don't really care. If you look at any research paper, I know I'm really ranting now, but if you look at any research paper on OBGYN, and you look at the endpoint, you read the material and methods section, and you read the endpoint's almost going to be neonatal mortality or neonatal morbidity. And occasionally things like C-section rate or something like that. It's never going to be, geez, how's that baby doing at age 2? Or how did that mom's breastfeeding go? Or how much postpartum trauma did mom suffer? Or what's the baby's microbiome doing? How's that baby's chronic illnesses? None of that is measured because it's messy. They can't really quantify it, so they don't think it's important. I would tell you and your listeners that how we give birth matters because nature designed it that way over eons. And nature doesn't do things that are stupid. Does nature always come out right? No, nature's formidable. Sometimes bad outcomes happen. We all know that. Right? But nature's design is perfect. And when we intervene with nature's design, we ought to be damn sure that our intervention is safe. And that's something that my colleagues have foolishly ignored. My college, I think your college is probably still the same, is still recommending 5 different, let's see, 1, 2, 3, 4, 5, 6 different vaccines, 4 different injections to pregnant women with substances that have never been tested for safety in anybody in a randomized double-blinded controlled trial, let alone in pregnant women, let alone giving 3 of them with 5 antigens at the same time at 28 weeks. The COVID, the flu, and the DTaP shot. I don't know if your country does that, but I'm pretty sure they still do. And then probably still recommending the RSV vaccine at 34 or 35 weeks.
Yeah, they are.
We could spend a whole nother podcast talking about why that makes no sense. Even if you believe in vaccines, it makes no sense. It's not how babies' immune systems work. We shouldn't be giving things like heavy metals and stuff to pregnant women. There's something that's been around since the dawn of science, which is called the precautionary principle, where you don't give experimental things or things that aren't tested to pregnant women and lactating women and newborn babies. You just don't do that. And yet that's violated in every hospital every single day with no concern for long-term outcomes.
Well, it's funny you say that. I received the COVID vaccine after a long-term battle of trying my hardest to not get it. And I was 12 weeks pregnant, and then my daughter, her placenta stopped working at 36 weeks. And when she came, and I decided to still have her at home because that's where I felt safest, and I still want to ensure that she was not going to get taken away from me as soon as she came out. People still never see why I would do something so reckless. Yet to me, it just felt that exactly what I needed. We decided to transfer in. Well, she did show signs that she needed support, so we transferred in. And I never forget when I was asking the nurse, like, what happened, which I never got an answer from, and the OB, who was incredibly horrible to me, treated me disgustingly. I knew in that moment, I thought it was because of that vaccine. But there's no one could say that to in open arms, and that brings me to where I was leading into my next point with you, is that about 25% report that they have some sort of PTSD, women, mothers. And I want to ask you and when you were talking, I was getting emotional because I think as we're listening to this and listening to you talk, I'm thinking about all the women before me and all the mothers who have basically been raped, and they have been told that other people are allowed to do what they think is best by them and their policies with their body. And because they're in this setting, that it's been allowed to do. And as you were talking, I couldn't help, but I was getting emotional because I'm like, how is nobody else seeing this? This is rape before our eyes, and women are literally being abused in the hands of a professional. I want to ask you, what do you think the repercussions are to women who are starting off their parenting journey, going through going through birth trauma? Because birth trauma, I don't think lands heavy in the heart of women who haven't gone through it. They don't have maybe perhaps an understanding of what is actually going on and what's the repercussions of their mothering journey when their birth has begun in a traumatic way.
It's a really excellent question, and I'm really sorry that I'm stirring these emotions in you, but it's important. It's important that my profession has no self-reflection. They're not able to look at it because the cognitive distance is too strong, and and we're getting into the psychology of it, the mass formation. Doctors don't stand up for something because you saw what happened to doctors who did. They were deregistered. They lost their license. They lost their livelihood. Some of your people were even put in prison because they were not following the thing. So who wants to do that? So the easiest way is to keep your head down. Now, what you're asking me about the effect on mothers and stuff like that when they start out that way, I will fully admit I'm not an expert in pre and perinatal psychology. We interviewed somebody recently on our podcast on that. And I learned a lot about how, again, nature designs a system where babies are developing in conjunction with their mothers through communication that's both physical and metaphysical that we don't even understand. And when that is interrupted, both the baby and the mother are traumatized. And how that effect plays out, I can't really say, but it's clearly obvious that there's something wrong with our society. You don't have to be, I mean, you have to be blind and not to see that how we are born and and how we're nurtured and how the woman who gives birth, how she is treated, how she's allowed to feel strong or weak or what is going to affect her the rest of her life. Look at, I don't know how my birth affected me because you'd have to have a parallel universe. But when I was born, my mom had twilight sleep and I was pulled out with forceps because in the 1950s, that was standard of care. Brilliant, wasn't it? Jesus Christ. So how do I know how that affected me? But I can tell you this, my mom loved me, but there was a detachment between me and my mom that may have occurred because of how I was born. And my mom, this is going to make you cry as well. My mom had no memory of my birth. She was put out. When she woke up, there was a baby over in the warmer. She doesn't remember. She's passed on now, my mom. But she has no memory of her birth. In one of our documentaries called Heads Up, The Disappearing Art of Breech Delivery, there's a woman named Elizabeth who comes into the hospital for help with a breech baby, which baby's already protruding out her vagina. And they tell her to push her legs together, don't push. They put her in general anesthesia. They didn't allow her husband in the room. And she says on the video that it hurts because I have no memory of his birth. So this baby was born without the mother or the father witnessing the birth of their baby. How does that not affect you? I met this woman 4 years later at the premiere of the documentary. She'd already had a successful VBAC. She would have had an easy vaginal birth. If she'd been stuck in a traffic jam for 5 minutes longer, she would have had a vaginal delivery. It's ironic. But she'd already had a VBAC, but maybe it's because we were there for the event of the screening of the film. But all she could really talk about was how traumatized she was by the birth of her first child. So there's no question that it affects things downstream. We have no way of knowing because you can't do randomized controlled trials of treating women badly and treating women well and then seeing how they do 10 years later. Nobody's going to do that kind of a study. But it's just common sense. It's just human to understand that when you treat somebody poorly or when you deny them their own intuition, when you bully them, when you force things upon them that they don't want, when you coerce them using terms like it's safety and you don't want anything to happen to your baby, do you? These things have to come back and reflect upon us. And every time you look at that child, you have chemistry going on inside you that we don't understand, that even the pre and perinatal psychologists don't understand. But if people are real interested in this subject, they should look into it. I'm sure your country has a branch of the pre and perinatal psychology people. And that would be a very great person to have on your show, is to have somebody to talk about that kind of thing, because it does matter. And she was very eloquent about how the process of growing inside your mother, and when your mother is happy, what is that doing to your neurons that are forming inside the baby when they're being bathed in dopamine and oxytocin as opposed to adrenaline and cortisol and other stress hormones? When a woman is living in fear the entire pregnancy because she's in a war-torn country or because she's going to see a maternal fetal medicine doctor who's scaring the crap out of her about her baby, not, only being the 8th percentile. She's 5'2" and her husband's 5'6", and she has a small baby and they're worried about it because all babies are measured on the same graph because they don't individualize their care because their system doesn't allow it. I mean, it's it's so obvious to you and me talking about it right now, but to them, living in that system, they don't see it. And how can a woman not be affected by that? And by the way, we haven't even mentioned the fathers. That's another whole topic of how are the fathers affected? In the medicalized model, how is the father treated at the hospital? They're treated as an annoyance pretty often. They're often pushed to the side. They're disempowered. I think of what we used to do in the hospital. When a woman was being taken back for an epidural or a C-section, the dad was made to sit outside in a little stool, little chair. We'll come get you when we're ready. And of course, they dressed them up in a little blue jumpsuit and with a little boofy hat, and set him off in a corner. What does that do to the relationship between him and his baby and him and his spouse? How is that affected when she is bullied by the doctor and he just sits there and does nothing? And she witnesses him sitting there and doing nothing. A man's job is to protect his family. That's the primary role of a traditional male. We've tried to destroy traditional males as well. Another topic for another. Gee, look at all the topics we could have. So what we're doing not only to the baby's psychology, the mother's psychology, but also the father's psychology. I will tell you that I've witnessed fathers to support their woman through labor for 16 hours, 20 hours with no sleep. They're cooking something. They're making food for them. They're supporting them. They're squeezing their hips. They're rubbing their back. They're catching their own baby. These men are going to be, I don't think you need a study to tell you they're going to be better fathers, better husbands, more likely to stay in a marriage when they witness the power of the woman that they chose and what they can do, and not being disempowered by the doctors and nurses keeping coming in and interrupting things and telling them they can't do this and they have to do that. How strong that bond will be between them. It's not perfect. Things happen. But, when a father witnesses the birth of his child, that there's an attachment there. Now, my friend and former colleague who passed away last year, Michelle O'Donnell, would say that women should birth alone. And I understand why he says that, because that's nature's design. No other female in the mammalian species goes off to birth and brings her partner with her. They don't do that. But even species that, well, I guess it's only in birds. Are there mammals that marry for life? Yeah, no, I think birds. I'm not sure there are mammals that marry for life. I'm not sure that's how the mammalian world works. Anyway, they don't bring they birth alone. But I think, for the sake of the way our society works and the bond of our family, which has been sort of diminished and destroyed over also that same time period, by the way, that 50 to 70 year time period, we've gone from 70-80% of children being born to in a two-parent family to more than half of children in my country now, I think, are born to single mom. I'm not sure that that's accurate, but that's a number I seem to remember. That we've just taken nature's design. We've taken things that worked for decades or millennia in the family, and we've destroyed them all. And I don't think it's accidental. I do think it's purposeful. I think, there's nobody sitting in a room smoking cigars and saying, ha ha ha, let's do this. But the system is working just the way the people running the system want it to work. Because the more you can disempower somebody, the more you can confuse them, the more you can frighten them, the more you can isolate them, the more you can control them. My friend Shelley Poulter, who is a doula in England, has this talk she gives where she lists all these things that they do to you in labor and delivery. Isolate you. I can't even think of them all, but there's a whole list of them. And and you can relate to them, everything happening in labor and delivery. That list actually comes from a domestic abuse website of how domestic abusers treat their spouse. And everything that happens is exactly what happens to many, many women when they go to the hospital. Using the baby against you, othering you. I can't remember them all, but it's remarkable when you read that thing and then you hear that, oh, well, that's from a domestic abuse hotline, and your brain immediately goes to that's how I was treated in labor and delivery. There's very little difference.
It's scary.
And one is considered standard of care, and the other is considered criminal.
Mm.
Who are we kidding?
There's a few things I want to circle back on. Before I forget, I'm just going to mention that if anyone's listening and they are looking to speak to a traditional midwife, she's now deregistered, but please contact me. I have an amazing woman who was registered at the time I had my first daughter, but I did interview her on the podcast a while back, and she speaks into her um, point where she just felt there's no other way. I need to deregister because I'm here to serve the women and I'm not allowed to. So I'm deregistering. Anyway, I wanted to just plug in that because I think a lot of people don't know who to speak to and can't find anyone that understood, because as if you're listening, you can kind of paint the picture that there has been so much propaganda to tear us all apart that not even our own family members as women are going to support what we want. And sometimes we have to find a stranger that understands us. And I think throughout this interview already with you has been emotional for me, because I have done what my intuition has told me to do whilst at the hands of losing the connection with people. And we are wired as humans to want to fit into our circle and want to be loved by our circle and want to be loved by our family. So when you're doing something that is quote unquote selfish and choosing something that feels good for you that others deem irresponsible and selfish, it's an extremely difficult time to stand by your own needs, and potentially at the loss of someone you love who isn't going to understand you, doesn't support you. And I just want to honor that, because that's a really incredibly hard journey, one I've walked. And if anyone's listening and have done that as well, I can see you. And it's just, it feels like it's a breath of fresh air when you can have someone sat beside you who understand you. And this is just my next thing as we talk about studies, and I have a lot of really good friends in the professional space, and they and well, everyone really, they all are wired now that we need to have a study to prove something. But I just want to say, if you actually sit and actively listen, now actively listening isn't something a lot of people are able to do anymore, where you actually can ask a question and sit and shut up and listen to someone's answer. And what I strongly urge us to do as people, sometimes stop reading the studies and actually ask women who have walked before us and who have done this before us and say, how did that feel for you? And then just sit and listen, because I think we've lost the ability to sit and listen, even if it doesn't feel comfortable in our body, or if we don't agree. But what they did was right by us, it was right by them. I think being able to just sit and listen and learn, because you shared that in your journey, you were listening to women. And where, as you were saying that at the beginning of this episode, that you were having mothers and midwives come in and question what you were doing, you obviously had an ability to sit and listen. And even though you may have not agreed, you still took it on board and said, well, that's how they feel. And I'm hearing that. We have lost the ability to do that. And I, being that person that's come into the system, and when they've asked me, and I know a lot of women who are choosing not to immunize and be on the immunization schedule, and so many of us are so fearful of even taking our children into the doctors to get a cold or a flu checked, because of the question, are you on the immunization schedule? When was the last? Are they up to date with the vaccines? We're actually so fearful. So because of not knowing what to say, and I think for us and us women, and I'm speaking to the women who have sat beside me listening and have been in this position, you do not have to have the right script and you don't have to say the right words. You can just speak from your heart and say, it doesn't feel right to me. And that's all you need to say. And if the person on the opposite end, you can feel their energy. We all have this incredible gift within us that we can feel what is going to be heard from the opposite. You can feel someone's energy if they're not receiving. And at the end of the day, if the person on the other end of you wants to understand you, they will. If they don't, they won't. There is no point trying to shift them, but you can feel. And obviously that has been you in your journey. And I just really love that you have been able to sit and go, I want to hear how
Well,
you feel.
I'll wrap it up by just saying this, Ebony. What you just said was brilliant. Um, and this is what the midwifery model is. The midwifery model doesn't do volume. The medicalised model has shifted from individualized care to volume. And when you're doing volume, you do not have the time to listen. You
Mm,
want to talk and you want to move on to the next task. And what you said about reading the room and feeling the feeling, when anybody listening, when you go to see your practitioner, do you feel better when you leave than when you came in? And if you don't, then wake up and understand that that's the vibe that you're getting because that person that you're talking to is not really interested in you. They may be, if they could go out and have coffee, they'd be interested in you. But in the model that they're limited to, they have to do
mm,
volume, and they don't have time to listen to your story. They don't want, when you ask a doctor something like, I don't really want to be induced by 40 weeks or 42 weeks. I want to let my baby come whenever they want. If they roll their eyes, if they look exasperated, if they make you feel less for doing that, if they label you as non-compliant on the chart, um, that is not a practice you need to stay in. One of the things that we've forgotten as women and families is that we are the consumer. We have the right to choose our practitioner. Yeah, it's all government this and government that. Not necessarily. You could save money and you could hire somebody privately. There are private options. As you said, you can tell whether that person is receiving you or not just by their
mm,
body language and by their facial expressions and by their eyes. Like when I was talking and I was on one of my long monologues, I was watching you. And I could see your eyes sort of well up a little bit. I could see you, I could see that you were taking in what I was saying.
mm,
Other people would be multitasking. We live in a time of multitasking, where people are constantly texting as they're talking to somebody else or doing other things. What you want when you're pregnant is you want somebody to be able to pay attention to you. What you deserve when you're pregnant is someone, and the system is not set up for that. And again, that's purposeful. They don't want relationships because relationships means that you're going to care more about the person that you're supposed to take care of. And that interferes with those people that are running this megalithic model of volume-based revenue generating practice is not to have that individual relationship. And they've purposely destroyed that. They purposely went to the managed care model with a shift mentality to do that. What we deserve for our own well-being and the well-being of our baby is to have a personal relationship. And even if you love your doctor, the way the system is set up is that the chance of that doctor being on call the night that you go into labor is going to be very small. And therefore, they're going to offer you to be induced on a day that they're working. And then you've just started the whole process down that cascade where you're intervening in nature's design. So if you build it, there was an old movie that called Field of Dreams. If you build it, they will come. If you demand certain things, then the market will change. And if you demand midwifery type care and you say, after your 6 minutes with your obstetrician, he's ready to walk out the room and you say, excuse me, I'm not done talking to you right now. And what are they going to say? I'm sorry, I don't have enough time, more time for you. Say, no, and by the way, you should do this before you're even pregnant. You should interview the local hospital and your local doctors to find one that you resonate with. So you don't find out, at 34 weeks that this doctor isn't going to do what you want them to do. Invest time, invest money in it. When we move to a new community, before we move as a family, we often check out the schools. We check out the parks. We check out where's the shopping center. We check out the crime rates in our community. We even go to a child molester website to make sure there's nobody living in our area, that sort of thing. But what we don't check out is our local hospital. We don't. Some hospitals have C-section rates of 30%, others have 60% C-section rate. You should be checking these things out. Make smart choices. Make demands. This is a life event. It's not a medical procedure. You're not having your bunion operated on or your appendix taken out. Even though that's the way you're treated when you go to the hospital. You're there for a life event. And what we want, well, I'm sure what Ebony wants, is for women to have powerful, strong, happy memories of their pregnancy and the birth of their children. And it's very difficult to get that these days in the system. We can change that.
For the rest of my time with you today, I really want to have a primary focus on couples that I can send this episode to that are wanting to become parents one day. And they perhaps look at home birth as scary or fearful. Can we just break down? And I think a lot of men as well have sometimes more fear than the woman. So my following questions too are going to be based on I want to get into the minds of supporting those women to make sure that they acknowledged prior to going to pregnancy on how they can have the birth that they want, because most of the time women in their first pregnancy, they follow what they're told to do. Let's just call it by the government. Then it leads to the birth trauma. Then the following birth, they might then go, okay, now I'm going to step up and I'm going to make a plan and I'm going to fight back and then I have a bit better. Then the third, they go have a home birth. Before going into epidurals as well, because I really want to I've heard you speak about this and it's incredible how you speak on it about what happens when an epidural is administered to the baby and the mother. And I'm going to get into that. But first, if you could speak directly to parents that are not yet parents and they want to have a natural birth, what would you say to them?
I'm hesitating here because not all parents are the same. And so some people have different values and different customs, and you have to respect that. So this is a general statement. But if if we know that your chance of having a C-section, if you go to the hospital with your first baby, is going to be probably higher than 40%, because the rate of vaginal delivery for multiparous women who've already had one baby, is going to bring that number down, and yet your level is 40%. You're walking into a hospital with your first baby because you're scared or you're nervous, and you think, well, I'll have my first baby at the hospital. Well, you probably have a 50% chance of having a cesarean section, which then will affect all your future pregnancies. So I don't know if this is the question you're asking, but I would tell any couple that's considering having a baby, whatever else, to rethink the idea that they need to do their first one in the hospital. We find that looking through the literature, and including my own experiences and my own papers that I published, the success rate from women having their first baby at home is about 80%. And of the 20% who aren't successful at home, about half of those will still go on and deliver vaginally at the hospital. They'll get an epidural, they'll get Pitocin, they'll go on and deliver vaginally, they'll get a vacuum, they'll deliver spontaneously, whatever. And maybe 5 to 10% of them will get a C-section. None of those C-sections, or almost none of them, will be emergent. They will basically be for failure to progress or restive dilation or fetal intolerance to labor, which is more like iatrogenic overstimulation of labor and failure of doctors to recognize it and wait. So that would be my definition of what failure to progress often is. But nonetheless, your chance of having a C-section if you plan a home birth with your first baby is going to be 5 to 10%. If you go to the hospital, it's going to be 50%. I'm not making that up. That is numbers that you can look at. You can find those numbers worldwide and do that. So you have to have that information. And again, how do you give consent to something when you're not given information? And the idea, we could go off on a tangent and talk about informed consent. We could really be here forever talking. Informed consent is what you give to your doctor. And how do you give informed consent if you haven't been given all the information? Doctors don't give you consent. Doctors give you information. You give consent. And in order to give informed consent, you have to know the pros and cons of all the choices. You don't just need, if they want you to have a C-section for a breech birth, for instance, they will tell you the downsides of a breech birth, but they won't tell you the downsides of a cesarean. They'll tell you the pluses of a cesarean and the downsides of a breech, because they're skewing their counseling to get you to do what they want, to funnel you down the path they want you to take. This is classic. This is not the way it should be. So as parents, again, you mentioned earlier, Ebony, about the pressures they're going to feel from their loved ones and their friends and their community. And it's very hard to stand up to that. I don't know how many in your country resisted the COVID tyranny. In my country, it was about 30%. So 30% of people, there's 350 million people. That's a million people. Excuse me, 100 million people. 100 million people that were able to say no to all the tyranny. So there's something in us that we have that we just need to activate. And when the outcomes in the hospital are not great, you need to understand that it's not necessarily safer to go to the hospital. And by the way, safety isn't something that we can define. Safety is something that an individual feels. Some people will feel that rock climbing is safe and they love doing it. Other people will think, well, you're out of your freaking mind. That guy that climbs without ropes. Yeah, I mean, I've seen his documentaries; they're amazing. But that to me is not safe. He would say, yeah, but I take the risks and benefits, and I choose to climb without a rope, and I choose to sit in my chair and watch you on television. That's my choice. Okay. So safety is not defined. You ask two people about what they feel is safe. Some people are going to think that the hospital is safer. You, as a person, felt that the hospital was less safe for you. So we can't try to influence everybody with the kind of judgment that we have. I just don't want to. I don't want to say that there's one thing that all patients should do, because. And by the way, we shouldn't even use. I shouldn't. I've been trying to use the word client for most of the talk. Sometimes the word patient slips out of my mind, because patient is a term that medical system uses because patients are supposedly sick. That's why you're a patient. But pregnant women, when they come to the hospital in labor, are not sick. So they shouldn't be using that term. It's one of those disempowering terms, like when they make you change into a hospital gown or they put you in a bed. The hospital puts the bed in the center of the labor room because that's how the architects design the hospital, because they think of people going to the hospital are sick. But you're going to the hospital for the one thing that's not sick. It's a normal bodily function. Yet the hospital designers think of it as being sick, so they put you in a bed. The reason I bring that up, because if you've ever been to a home birth and you walk in quietly while a woman's in labor, how often do you find her in bed? And it's almost never.
Never.
She's moving, she's pacing, she's squatting, she's in the shower, she's in the tub, she's out in the backyard walking around, she's doing the mile circuit, she's going up the stairs, she's leaning on her husband, that sort of thing. She's not laying in bed. So again, the whole mindset of that system is screwy. Now, if that is where you feel safer, that's where you should go. But you should go with eyes wide open, not eyes wide shut. And unfortunately, you're not going to get eyes wide open counseling from people that work within that system. One, they don't know what I know. Two, they don't have the time, even if they did know it, to give it to you, because they're employees. They're given a schedule. They don't have much say in their schedule. They don't have the time to go through all these things. So they skew their informed consent to get you to do what the model of care that they practice in wants you to do. And again, that's a violation of our basic tenet of medical ethics, and yet it's done every day in every single doctor's office in every single hospital, without batting an eyelash. And they will tell you that they're practicing good medicine, and I will tell you they're not. And we could have that debate if they would ever debate, but they don't. So I don't know if that answered the question. I'm going to have to wrap up soon. I just want you to know, Ebony. Okay. So
That's okay.
not that I would want to not keep talking, and I can talk a little bit about the epidural if you want, or we can save that for another time.
Yeah, we're going to have to get into another conversation, aren't we? But yeah, would you like to quickly
just briefly, yeah, because you brought it up, I'll just briefly. This is a theory, you can't prove it, because there's no way to quantify it or study it. But again, it gets back to, is nature smart or is it not smart? And I
Mhm.
would say that nature is very smart. Um, and nature has designed a system between mother and baby where throughout from the moment of conception, the mother and baby are communicating. They're sending signals back and forth. Sometimes it's hormonal, sometimes it's chemical, sometimes it's metaphysical or energy we don't understand. Uh, Sometimes it's bio. I don't. There's other facets involved, but baby's sending signals to mother, mother's sending signals to baby, back and forth. There's this beautiful symphony going on. And baby senses when mother is happy, baby senses when mother isn't. Baby tries to send out signals to help make mother hungry, so mother eats, so baby gets food. There's just this thing going on. And obviously these things are something that's very hard to prove. But why would nature design it otherwise? That makes perfect sense. So when the you know the question that really comes down to, what's the point of labor being painful? Because the putting the biblical story aside of Adam and Eve eating the apple from the forbidden tree and then being punished by saying you kicked out of Eden and labor will be painful. But all mammals labor is painful. It doesn't benefit a deer to crying out in labor. But we know it's painful for them because they have actually done studies on sheep and other animals on looking at catecholamine levels and things like that. And even though they're not yelling out four-letter words or screaming, they are experiencing discomfort. Right. So my theory, and I'm not the first person to come up with this theory, but I've propagated it because it makes so much sense to me, is that labor is painful. So mother secretes hormones to help her with the pain. She secretes endorphins, which are your body's own opiates. She secretes oxytocin, which makes her feel warm and loving and makes her connected to her baby and say, I'm going through this for the right reason. I'm going to have a baby. And she secretes cortisol to handle stress. And she secretes adrenaline to help deal with the pain. And what does adrenaline do? It spaces out contractions a little bit. So all these things together, she's making this beautiful cocktail. And as she's helping herself, her baby's world is suddenly changing from what it's been for 9 months, which is living in this little bubble, happy as a clam. And suddenly now the uterus is contracting. And while it's contracting, blood flow through the placenta is diminished. So baby's exchange of nutrients and oxygen is diminished for 40 or 60 seconds or whatever. And then it comes back. But that's stressing the baby out. And the baby's now, maybe the water breaks and the baby's now getting squeezed. And his head is getting squeezed or its butt's getting squeezed if it's breech. And that's strange. It's a strange feeling. But baby's connected to mom because every 3-4 minutes, baby's getting a waft of mom's endorphins, of mom's cortisol, of mom's adrenaline, of mom's oxytocin, and who knows what other hormones are involved in that. Serotonin, dopamine. I mean, there's so many hormones that are involved in that because mom and baby are experiencing this together. Then a mom says, I can't take this anymore. I'm going to get an epidural. So mom gets an epidural and she's no longer in pain. So she stops secreting all these hormones. Yet the uterus keeps contracting. Sometimes it even spaces out and they have to add Pitocin, which makes the contractions even stronger. So now the baby's getting contractions every 2 minutes or 3 minutes, but there's no mom there anymore. The reassurance that's coming from mom, the communication that they've had hormonally in other ways is now severed or altered. And so baby's left to deal with its own on its own, and it doesn't know what to do. So how often do we see a woman getting an epidural and then her contractions space out, getting Pitocin, and then the baby's heart rate pattern begins to change. And then it becomes worrisome. The doctors and the nurses don't like it. And they think, wow, you're only 6 centimeters because they've just done an unnecessary vaginal exam on you. And your baby's not tolerating labor very well. Well, your baby's not tolerating artificial labor. A numb mom and artificial Pitocin, which is not the same as oxytocin that mom secretes. It gives her that, crosses that blood-brain barrier and gives her that warm feeling and gives babies making its own. All that stuff, that's all disappeared. And so the baby now is struggling and they think, oh my God, the baby's not tolerating labor. We need to do a C-section and boom. And the rise of cesarean has paralleled a lot of things, but one of the things that's also paralleled is the rise of regional anesthesia. They go along together. When epidural rates rise, cesarean section rates rise. They can blame it on anything they want, but they can't just dismiss it what I've just said as illogical or not to be considered. They don't want to consider it because they want to give you an epidural, partly because there's no money in not giving you an epidural, and partly because it's easier for them when you're laying there comfortable that they don't have to deal with you as much. And if they have staffing shortages, just we'll put an epidural in, we'll make money on it. You'll be pushing the buzzer less. We'll have to pay attention to you less. All these things fit the model by which they want to practice, but none of it takes into account nature's design. And that's the short version of the longer story. It's not even a short version, but that's that. So again, every time we intervene in nature's design, there may be some benefits from it, but there will always be ripple effects. There will always be downstream consequences. And we need to look at those before we use this in mass production. And we don't. Obstetrics is filled with stories like that. We used to x-ray women's pelvises, and then babies were born with cancer, with problems. We gave thalidomide for women who had hyperemesis that caused babies to have limb defects. We gave diethylstilbestrol to prevent miscarriages, which caused women to have Mullerian anomalies, which are like cervix, uterus, fallopian tube anomalies. We've done continuous fetal monitoring for 60 years now, with the idea that it was going to prevent intrapartum death or cerebral palsy. It has done neither. And after 60 years of use, not only is there no evidence of benefit from it, there's evidence of non-benefit from it, yet hospitals are completely reliant upon it because of medical legal concerns, and also it's a labor saver, they think. So they put all these things in place without ever asking, do they actually do good? And if you actually look, most of them don't do good, and they do them anyway. And these are the people that are sitting in judgment of you and your idea of wanting to have a home birth, or your midwife wanting to support you. They're looking down upon them. They should clean their own house first. And they're not going to do that because it's easier to pick on the person over there than it is to look at your own problems. I think in The Wizard of Oz, it's even popular in your country, that the original movie, The Wizard of Oz. Everybody's seen that, right? Yeah. There's a scene where it says, pay no attention to that man behind the curtain. I am the great and powerful Oz. They want you to look at this flashy thing over here and pay no attention to all the machinations that are going on behind the curtain. And that, that line wasn't written by chance. People that, the person who wrote that, I can't remember his name, who wrote The Wizard of Oz, there's a message there. It's a societal message. It's not just something that's fancy on the screen to watch. And we should learn from these things, but mankind just doesn't do that kind of thing, especially when money and power are involved. History doesn't seem to matter very much. We're not doing well. We can do better. And you, as an individual mom and dad, you have to take responsibility for your family. Do not turn it over. Do not abdicate your responsibility to a system that may pretend to have your best interest at heart, and your individual doctor may, but they work in a system that does not have your individual best interest at heart. It doesn't. There, I said it.
Thank you so much for your time today. I really thoroughly enjoyed this conversation, and I cannot wait to share it with my community. So thank you so much for taking the time to have this conversation with me. How can people find you, and where are you now working with anyone, or are you doing chats with people?
I'm not birthing anymore. I've retired from that. But I do counsel. I do consulting and meetings online. And so people who have questions, often people will be told with twins or breaches especially, but also people with hypertension, diabetes, or cholestasis of pregnancy or whatever, they'll be told one thing by their doctor, and they have the intuition that that's not right. So they can reach out. These are generally paid conversations. If it's a very simple question, I answer all my own emails and I'll answer it. But if it's more complex or it requires more history, then it's a paid consultation. They can do that. I have a podcast, the Birthing Instinct podcast, with my co-host Bliss Young, who's a midwife, traditional midwife, wonderful person. I am on Instagram at Birthing. All my stuff is Birthing Instincts. So Instagram, I'm Birthing Instincts. I don't really do TikTok or Twitter or those sorts of things. And then my website is birthinginstincts.com. And I have links to all my events and things that are coming up there, and all kinds of the information. We also have the Birthing Instincts podcast website, which is birthinginstinctspodcast.com. And from there, you can even link to our Patreon group, which is a small community of about 1,400 people. So I guess it's not that small anymore, with many different tiers where Bliss and I will do extra content, and I'll do some deep dives, and you can watch our podcast video instead of just listening to them. And there's also all kinds of special things. We also have a monthly peer review where you can actually get CEUs if you're a birth worker. And we have a monthly Q&A. And then Bliss does a monthly village prenatal. She has prenatal talks with 20, 30 women that come on. And so you can find a sense of community there. For those of you that are feeling isolated in your beliefs because your family or community aren't supporting it, it's one of those great options that Patreon has offered, that you can look into. So, that's basically it. I wrote a book a long time ago called Fearless Pregnancy, but the premises are still very much current, but some of the data is not current anymore because obstetrics has changed since 2010 when that was written. And then I published some papers, which the links are on my website, on home breech and home twin delivery, as well as a case report and on home birth with an obstetrician. And people can read those if they're curious about my data. My data doesn't reach statistical significance because it's just me and the numbers aren't great enough. But the twins, about 100 sets of twins, and the breaches were 60 breaches that were done at home. And people can get an idea of what's possible by reading that. And it may not be possible in your community because no one knows how to do it. It's one of the shame. And then my biggest thing, and I almost forgot to talk about, was that I go around the world and I teach a 2-day seminar on breech and twin skills, which is my passion. And I will continue to do that until the day I can't speak or walk anymore, because it's so necessary. There are very few options for women anymore. And if it wasn't for me and Breech Without Borders with our two organizations, there'd be really nobody that's teaching these skills anymore. So a shout out to Breech Without Borders and Rick Safries for what they're doing, and then my Reteach Breech programs. So I hope that people will just look into it. And if you're not interested yourself, you share it with your family members and friends so that people can make informed decisions about what's going on, as opposed to being scared into decisions that may not benefit them down the road.
Thank you so much for what you do. And for the person that's listening here with us today, thank you so much for tuning in right to the end. This is a big episode and it has taken a long time for us to cover. And I'm sure I'm going to have to do a part 2. If this conversation has resonated with you, please send it to a friend, a family member, or your partner so we can continue having these important conversations and work together towards safer and brighter children for ourselves, women, and our family, and our husbands and fathers. As always, thank you for being here with me on Align Yourself podcast, and I'll see you soon.